Hi. Um, I always do what Sam Licio tells me to, so I'm here. I've really enjoyed the morning, and I'm looking forward to running through healthcare with you. I just published a paper. It's available on my LinkedIn site and elsewhere. It's called Generative AI Complements, Not Substitutes in Canadian Healthcare at the Start of 2026. It is an empirical paper about what is going on, and it's about generative AI, not about AI. So I try not to confuse deterministic stuff and generative. I think they're different. I'll come back to that. My conflicts are on file. I have several. And the CSA Public Policy Group is so great. They are a great team that have supported me on this, and a big thank you to Sunil Johal and that whole team. In healthcare, we have very big problems. Workforce exhaustion, rising demand through the 2040s. We're about 30–40% below peak demand at the moment. It's really going to get very bad. Patient responsiveness, bureaucratic friction, you guys know this, or if you're outside of healthcare, you feel it in your lives. These are major problems, and anything we do in generative AI needs to come with a balance of risks, because the current system is not perfect. In healthcare, 3-point solutions in clinical practice have reached 30% in under 4 years. I wanted to say on the current slide, I love Jill Balser and Nate Glubish. I don't know if they stayed around or not, but I've been a fanboy of Nate's for a little while now. And I really encourage you to follow him because he puts interesting stuff out. And we need politicians talking about this stuff openly. My friend here, who's an MLA, who I talked to earlier, is a good example of someone who's using stuff and doing stuff, and I encourage you to talk to him as well, because he is staying and listening. Ambient Scribe, second screen CDS, patient AI. Generative AI was released commercially November 30th, 2022. By the middle of last summer, all 3 of these clinical applications had reached 30% usage in Canadian healthcare. Okay, that doesn't happen in digital health. That does not happen in digital health. But it happened quickly. Let me go through them briefly. CMA did this report, 28% as of August of clinicians using on a near daily basis ambient scribes. Why do clinicians use ambient scribes? Because it makes their life a lot better. Now, it does, if you get into the ambient scribe world and look at what's happening with the second and third generation projects. So the first generation projects are just hitting the academic literature now. The first generation projects show huge improvements on cognitive decline, huge improvement on cognitive load, huge improvements on more focused attention, eye contact with patients, and they're showing reduced pajama time, about an hour a day less staying up late filling out notes. Those are big things. The second and third generation projects, I heard one from Ottawa yesterday, are showing 1 to 2 emergency visits per shift for emergency room docs. That's about a 10% capacity expansion. Early days, unpublished, happening quickly. I think it's more like 25%. Second screen CDS, again, blew us away. No PHI, no integration with the EMRs. If you'd asked me 3 years ago, I would have said clinical decision support needs to have patient health information. Clinical decision support needs to be integrated with the electronic medical record. I was wrong. Our industry was wrong. These tools are being used 1 million times a day in North America. Slightly ahead in the US. very quickly becoming the standard of practice. So open evidence and doximity are the two big ones. I lived a bit of the doximity journey because I was on the Canadian company, Pathway MD, which sold to Docs and is now the Ask product. I don't own any shares anymore, so don't worry about that. I am involved with another competing product, but that's another story. OE and Docs are both very reliable, and they take yestertech crappy textbooks and make them usable. That's a general theme. Hillary talked about it with ODB earlier today, taking a shitty static website, turning it into something usable. Patient AI is replacing internet search. This isn't true just for healthcare, this is true for all search. I think search will die by 2030. I encourage you not to use search anymore. Always start with an AI. It'll help you get more AI fluent. The health conversations that are going on, there's a lot of edge cases in the news. The edge cases are important. We always need to make sure we do mainstream testing and red team testing. Mainstream testing will show us how people are using it. Red team testing shows us how things go wrong. Things do go wrong. But there is a lot of good going on there, even in areas like the mental health chatbots. What's happened? How did we get to 30% in a hyper-regulated industry like healthcare in 3 applications in under 4 years? We got there because we introduced all 3 as complements, not substitutes. Around the world, there are different approaches. In some places, they introduced it as substitutive. They said, this needs to be a medical device. In Canada, we did a principles-based approach on things like scribing and second screen CDS, and we allowed providers within a set of principles to use those tools. We kept a human in the loop, and we worked within a scope of practice. Turns out the lawyers are doing something similar. Turns out the accountants are doing something similar. It's a little less confusing for them because they don't have things called legal devices, and they don't have things called accounting devices. But we in medicine, we call it medical devices because we're not quite sure, but we do that. On the substitutive side, we have things that are making decisions in diagnosis or prognosis. Those are clearly going to need to be licensed and thought through at another level. They're able to act independently. They attract a huge amount of media attention and political attention. Doctronics stands up a simple prescribing app in Utah. It does non-street value drugs on renewals only, and even then sends 1/3 of them for checking. And it's on the front page of the New York Times, the Wall Street Journal. I think it even made it into Canadian papers. So substitutes are hard, complements are easy. AI is not one thing, okay? These are AI applications at the FDA. 90% of them are probabilistic. Some of them have a bit of generative overlay. It's all imaging and radiology and predictive stuff. It's all machine learning. It's not generative AI. It's not the same thing. When we look at Canada, Digital Health Canada, 2 sources here, Digital Health Canada and Arise. One of the previous speakers mentioned Stanford AI. She was right. Digital Health Canada published, and has published, and you should use if you're in healthcare, a list of all existing AI apps in the country. It's basically a Craigslist at this point. I pulled this in February, of the 178, I think at the time, 176 at the time, there was 1 generative substitutive app out of 176. They're just not there. That's all the point. The rest of the slides you can look at carefully if you care. Arise, same thing, big report, great material at Stanford. You must look at Stanford HAI if you're in this space. Same thing, generative as substitute, all under our REBs, all research only. Complements happened, substitutes haven't yet. Complements are at scale. They've passed through a third utilization. They're going to 100%. I think I've said everything on this slide. Shall I say it all again? Or do you guys want to read it? You okay? I'm going to pivot to the other side of the talk. Everyone gets my complements versus substitute points? Okay. How far do you think we can push complements, and how far do you think we should push complements? Because let me assure you that something that I thought 6 months ago was black and white has some really interesting shades of gray. So I did this little paper, right? You're going to go read the paper, please. I locked it down in December. I had to relock it down in February because everyone dropped new apps. I lock it down in February. Julia and others in the room have read it at that point, so I really did lock it down. Already, it's May, and it's pretty clear that it's getting pretty gray between complements and substitutes. I'm still pretty sure you should go the complementary path, but I've taught this a few times now, and usually when I teach this in a class, I spend an hour with yellow sticky notes. You know how we do it at business schools, right? I do pre-visit, in-visit, post-visit. What functionality would you like to see in, let's call it a clinical co-pilot. Let's not call it a scribe. Let's not call it clinical decision support. Those are just functions. What functions would you like? I did it with a senior group in Ontario, including, anyway, lots of senior people. There are 48 functions that a senior group in healthcare can come up with pretty regularly that should go into this. Of those 48, I'm going to say 45 are complementary. 3 are substitutive, but they're substitutive in some interesting ways, right? So technically, language translation for patient education is substitutive because it substitutes your judgment for what's on the paper. But there are legal ways to get around that. History collection turns out to be substitutive in some interesting ways as well. But basically, you can get there. But wait. This happened last week. But wait. What happens? Okay, so I have to go deep on this for a second. Second screen CDS is substitutive because it's a research tool that replaces the internet in North America, but not in Europe. In Europe, they decided it was, second screen, I misspoke. Second screen CDS is complementary in North America. It's viewed as a substitute for, that's confusing using substitute, a replacement for internet search that the provider used to do. And so because it's a replacement for the internet, we allow it to be used in North America. They don't allow it in Europe. Some question about whether they do or not. The company's fighting. That's fine. We can summarize from a scribe the history of the patient that we're seeing real time. The institution can write a piece of code that takes the summary from the scribe and puts it into the evidence bot and says, what should I do on this patient? Well, everyone except the Americans agrees that that's a medical device, right? I just took 2 complementary systems. I wrote a little piece of code in the middle and I made the thing go. You see the problem that I'm talking about here? You can, as we get more sophisticated here, we're going to start adding these things together. We're going to have some interesting regulatory issues. My answer, first line, and then I'll unsay it. So, trust physicians, push complements to the limit. Set clear ethical norms and value-based principles. This is the idea that Hillary introduced of minimum viable policy, which is usually called principles, I think. I'm setting you up for the debate later, Hillary. Physicians and other care providers are adopting Gen AI because they make their lives better. Get out of the way, help them do that. Explain to consumers how to use AI better. Gray usage of foundation models is a problem that we need to address pretty soon. Next big point. Gen AI is not a drug. Gen AI is not a medical device. Gen AI is an intelligence. We need a new regulatory frame. Let me expand that. Why is Gen AI not a drug? People may say this is obvious, but let's be clear. It doesn't have fixed composition. There's not a single indication. The static trial logic doesn't work terribly well. Pre-market sufficiency isn't good enough. Binary approval isn't good enough. And clear reverse attribution. Okay, a lot more in the paper on this, but you get the idea. What surprises people is when I say it's not a device. And the reason it's not a device is that there's no minimal or bounded function. The behavior isn't deterministic. It doesn't always give the same answer to the same question. My first bot, I'm a political junkie. My first bot, I was getting so angry at Trump because he was misanswering questions. I created a bot called Ask the Presidents, okay? And it only returns top-line newspapers. You can get it. I'll send it to you if you want it. It's out there somewhere in the ether. Presidential libraries, first-line speeches. It only answers from first-line sources. And my friend, who's a techie, he says, oh yeah, okay. So who will win a locked cage match, UCF style, amongst the presidents of the United States in a paired matching situation? And he asked the question. Anyone want to guess who wins? God. How did you know that? Damn right, damn right. Okay, but guess what? And this is what makes people crazy. Lincoln doesn't win every time. Particularly on pre-5 level OpenAI, if you run it on 4.3, you get about 60% Lincoln. Anyone else? Go ahead. Other presidents who win. Which one? That was a joke, by the way. It didn't get a laugh, but like Franklin was in a wheelchair, guys. Okay. And who's the third? Because that's right. Teddy's the third. I'll give you a hint. The third one is a thug. Huh?
Andrew Jackson.
Correct, Andrew Jackson. Jerry Ford sometimes, Washington sometimes. Jerry Ford was a football player. Washington was Washington and 6'4" and all that stuff. But it's not the same answer, okay? And people don't get that. People do not get that generative AI gives different answers to the same or similar questions different times. It's not a medical device, in my opinion. So what is it? I think it's a competency, and I think that it's competency-based licensing. But, the bureaucrats will look at me and say, you want the colleges to do this? Because the colleges are a force for good in our society? That was a joke too, guys. Okay, I need to cover this. Was it clear what I just said? Competency-based licensing? It's a big idea. It's out there now. People who are way smarter than me said it recently. Alan Bergman, Bob Wachter, and Ezekiel Emanuel are big names in academic medicine. They said it in JAMA about a month ago. So watch this idea, watch this space, get de-anchored. I have one more minute. Okay. I'm going backwards. Here we are. Gray usage. The UK and Ireland in particular, but the EU as a whole, banned some of these tools. Did their physicians not use these tools? No, their physicians did use these tools. Both Royal Colleges have issued reports showing usage in the 60% level of foundation models when harnessed models were disallowed. That's a problem. The EU overregulation, which was, by the way, walked back on May 19th. So May 19th, the EU has put out a new alert, walking back their high-risk stuff. The action is below the regulatory level. We need deployed tools, governance machinery, a statutory baseline that already exists, and then other emerging measurement systems. It has to be localized, and there's a lot of work to be done. It's an exciting time. Thank you for the opportunity. I'm coming back.